Good morning, everyone. Welcome to Cardiology Rounds. This morning we have two presenters from our interventional cardiology group. Dr. Kevin Chung is going to be speaking on pulmonary hypertension in multi-valve disease. Kevin graduated from the University of Notre Dame and completed his cardiology training in Western Australia. He also completed his master's in the area of pulmonary hypertension and left heart disease, and worked on the National Echo Database of Australia, developing a predictive formula for pulmonary hypertension. He worked in the Advanced Heart Failure and Transplant Service at Fiona Stanley Hospital prior to joining us and starting his Interventional Cardiology Fellowship. After Kevin, Dr. Anthony Poulin is going to complete a talk on management controversies in aortic stenosis. Anthony is a second-year interventional cardiology fellow. He completed his cardiology training in Laval. His training fellowship is also employing specific training in cardiac imaging and TAVR. And his main focus in his training is on the imaging and management of patients with aortic valve disease and disease of the thoracic aorta. So I welcome both of our speakers this morning. They each have a presentation that's approximately 20 to 25 minutes, and then we will proceed with questions for both of them. Please be sure to send in your questions in the chat box. So we'll start with Kevin. Welcome, Kevin.
Thank you, Dr. Stagnick, and good morning, everyone. The title of our talk this morning is Challenges in Evaluation and Management of Patients with Aortic Stenosis. My name is Kevin Chung, as previously mentioned. I'll be presenting with Dr. Poulin. The plan this morning is to talk about management of a patient with aortic stenosis, multivalvular disease, and pulmonary hypertension, and then Dr. Poulin will be presenting valve durability and risks of valve thrombosis and TAVI, and conduction disorders and risks of sudden death after TAVI. So I think the best way that I can depict this topic would be to present a recent case referral we received for a TAVI. So this is Mr. AS. He's 89 years old. In terms of his clinical symptoms, he's NYHA class 3 to 4. His main complaints are peripheral edema, intermittent nocturnal orthopnea, and exercise tolerance of less than 50 meters. He's never had syncope or chest pain. He mobilizes with a walker and lives in a self-caring retirement apartment with meal preparation and cleaning services. He attends to his own ADLs. In terms of his multivalvular disease history, he previously, he has severe posterior mitral valve prolapse. He had a mitral valve repair in 2007 with an Alfieri stitch, which has now failed. He has moderate mitral valve stenosis with a gradient of 5.4 millimeters of mercury, severe functional TR, and his anatomy was recently reviewed at the multidisciplinary valvular meeting, and he was not a candidate for both MITRA and TriClip. In terms of his aortic stenosis, he has moderate to severe low flow, low gradient aortic stenosis. His echo shows an LV-EDD of 49 millimeters, LAVI of 72, EF of 55%. His aortic valve gradients are 28 and 15 with a valve area of 0.98 and an indexed valve area of 0.54. His stroke volume index is 31 and his dimensionless index is 0.26. He has no AI.
just restart sharing there. You have to redo the stop sharing because they just see the first slides and then go on into yeah, that's fine. And then you have to end your presenter mode, right?
Hold on. Let me do it again.
But take it off and show this one. Then,
okay.
Then share.
Share.
Yeah. Good.
And then this one. And then this one.
This one. Good. And then go presenters. And then good. Should work now.
So these are the images from his recent transesophageal echo, showing a transgastric view of the tricuspid valve on the left, and to orientate you, I've labelled the posterior anterior septal leaflets and the corresponding right ventricular free wall and interventricular septum. The image on the right shows a slightly different angle of the transgastric view of the tricuspid valve, with coloured Doppler showing severe functional tricuspid regurgitation. In terms of aortic, Mr. AS's mitral regurgitation, the image on the left is a mid-esophageal long axis view of the mitral valve, aortic valve, left atrium, and inferolateral and anteroseptal walls of the left ventricle. Note the significant posterior mitral valve leaflet prolapse. On the right is a four-chamber view taken from his TTE, showing the severe eccentric anteriorly directed mitral regurgitation due to the mitral valve, posterior mitral valve prolapse. And also note the dilatation of his right ventricle, left and right atrium, and severe annular mitral annular calcification. In terms of Mr. AS's aortic stenosis, these images was taken from his TEE, with the short axis view on the left showing the left and right atrium with the interatrial septum in the middle, and the non-coronary, left coronary and right coronary cusps. Note the degree of calcification and partial fusion of the left and non-coronary cusps and reduced leaflet tip mobility. On the right, you can appreciate a long axis view, also mid-esophageal of the aortic valve, showing a heavily calcified and stenosed valve with color Doppler showing flow acceleration. If we look at the mortality of aortic stenosis, this study from Strange and colleagues published in JACC in late 2019 shows a survival curve of over 230,000 patients in the National Echo database of Australia. With the mortality trajectory of over 6,000 patients with severe aortic stenosis in the black line on the left slide, and the rest of the cohort in the red line over a follow-up period of 16 years. Specifically note that at two pre-specified time points of 1 and 5 year mortality on the x-axis, that the mortality of patients with severe aortic stenosis at 1 year was 29% versus 7.5%, and at 5 years the mortality was 67% versus 21%. I would also like to draw your attention to the survival curves of patients divided into no, mild, moderate, and severe aortic stenosis on the graph on the right. What is evident is that the trajectory of patients with moderate and severe aortic stenosis, labelled in purple and in black, are similar, with 5-year cardiovascular mortality and all-cause mortality with moderate of 43 and 61 respectively, and for severe aortic stenosis, the results were similar, with 50% and 65% respectively. The small diagram on the center adjusts for aortic valve area in 82,000 patients, with once again, you can see that the trajectory of those with mild and no aortic stenosis is on the top line is significantly different than the curves of the patients with moderate and severe aortic stenosis on the bottom line, and continue to widen during the follow-up period. To further examine the effects of aortic stenosis on mortality, the graph on the left shows aortic valve mean gradients divided into quintiles. The green, purple, red, and blue survival curves show the first 4 quintiles, where the aortic mean gradients is less than 9.6 millimeters of mercury. But once the gradients rise to greater than 9.6 millimeters of mercury, there is a significant increase in mortality. Furthermore, on the diagram on the right, it shows all patients with mean gradients greater than the 9.6 millimeters of mercury, distributed into deciles, ranging from 9.6 millimeters of mercury to greater than 39 millimeters of mercury. Specifically, if I can draw your attention to the patients with the mean gradient between 22 to 27.9 millimeters of mercury, there is a significant rise in the adjusted hazard ratio in all-cause mortality. This would be considered moderate AS in the current ACC and AHA guidelines. If we examine peak aortic valve velocity, which could arguably have less intra and inter-observer variability and less measurement error than valve area calculations, the results are similar, with peak velocity quintiles on the survival curve on the left, with significant widening of the survival curve once peak velocities were above 1.7 meters per second. On the bar graph on the right, with the grey scale representing 1-year mortality and the blue scale representing 5-year mortality in a cumulative fashion, there is significant rise in all-cause mortality when patients develop any aortic stenosis, and the significant jump once they develop moderate aortic stenosis, which is similar to the mortality of severe aortic stenosis. If we look at the baseline characteristics of this population, we can see that patients who develop aortic stenosis are older, but there is also worsening diastolic function with a rise in left heart filling pressures, illustrated with a rise in the medial E to E prime, and with worsening aortic stenosis and a reduction in the E prime velocity. As a result, there's a rise in left index atrial volume and also peak TR velocity, suggesting pulmonary hypertension. Though there was no subgroup analysis to examine the patients of similar age with and without aortic stenosis, this is an interesting point. To slightly digress but clarify how diastolic markers of left heart disease can predict pulmonary hypertension, I've previously developed a formula to predict pulmonary hypertension in the absence of tricuspid regurgitation using the National Echo Database of Australia. Using the NEDA, I enrolled 302,746 echoes and randomized them 1-to-1 into a development database and a verification database. NEDA was then linked to the right heart cath database at the Royal Perth Hospital, one of our tertiary teaching hospitals, to create the validation database. 887 right heart caths were performed between January 2010 and February 2015 and linked to their most recent echocardiogram performed within a median time of 7 days. We then used the development database to create the NEDA pulmonary hypertension due to left heart disease formula. Firstly, we tested it on the verification database in over 150,000 echoes to establish its accuracy in diagnosing pulmonary hypertension in left heart disease. Then we proceeded to validate it in patients who underwent the gold standard of right heart catheterization. The final common pathway in left heart disease then is an increase in left atrial pressure and diastolic dysfunction. Echo markers are the gold standard in assessing diastolic function, yet until now there's been limited data on the large population to assess the risk of pulmonary hypertension in left heart disease. Of the 99,025 patients with a measurable PASP or RVSP, we performed multivariate analysis on 305 echo markers in order to identify the most predictive markers of left heart disease and pulmonary hypertension. The table summarizes our findings. Firstly, patients who are older are more likely to have pulmonary hypertension. Looking at the septal E prime and the E prime values, patients with pulmonary hypertension are more likely to have reduced LV compliance and evidence of increased left atrial pressures. The filling patterns transitions from patients with impaired relaxation tending towards a pseudonormal filling pattern. As a result of impaired relaxation and increased left atrial filling pressures, patients with pulmonary hypertension developed an enlarged left atrium. And finally, the ejection fraction in patients with pulmonary hypertension are lower, suggesting that people who develop pulmonary hypertension are more likely to have systolic dysfunction along with diastolic dysfunction. Using the omega squared formula, we established the effect size of these variables, and the left atrial volume indexed to body surface area was the most significant marker of developing pulmonary hypertension due to left heart disease. Using the regression coefficients and constant, we created a predictive constant formula. Using the constant, we can calculate the probability of a patient using their age, and these 4 echo markers will whether the patient will have pulmonary hypertension. To depict how clinically applicable this predictive tool can be, here is a nomogram that can be used at the bedside or encrypted into any echo software to calculate the probability of pulmonary hypertension using these 5 variables, irrespective of measurable tricuspid regurgitation. For example, in the scenario on the left, we take a 7-year-old patient with an E prime of 5 and E to E prime ratio of 20, an E to A ratio of 2.5, and a LABI of 40. This would equate to a score of 9 and the probability of having pulmonary hypertension due to left heart disease of 60%. In order to establish the accuracy of the formula, we applied it to our development model, highlighted in yellow on the left. The area under the receiver operating characteristic curve was 0.756, suggesting that our model is 76% accurate in diagnosing pulmonary hypertension due to left heart disease. We then tested the formula on our verification model, highlighted in blue on the right, and the yield is very similar with an accuracy of 74%. When we applied our predictive formula to compare patients with pulmonary hypertension due to left heart disease with those with pulmonary hypertension not due to left heart disease using age and the 4 markers of diastolic function, the area under the ROC curve was 0.806. This suggests that our formula was 80% predictive of pulmonary hypertension due to left heart disease when compared to the gold standard of right heart catheterization. If we then applied our formula to compare patients with pulmonary hypertension due to left heart disease with those with no pulmonary hypertension or left heart disease, our model was 70% accurate in predicting pulmonary hypertension due to left heart disease. In terms of the pulmonary hypertension in patients undergoing AVR for severe aortic stenosis, what Melby and colleagues found was that pulmonary hypertension with preoperatively on the graph on the left was an independent predictor of mortality with worse prognosis in patients with severe pulmonary hypertension. However, what is more alarming is depicted on the graph on the right that shows the survival of patients with post-operative pulmonary hypertension. It shows that 36% of patients with moderate pulmonary hypertension and 55% of patients with severe pulmonary hypertension were dead at 5 years, despite having aortic valve replacement. So if patients with pulmonary hypertension do worse, how can we pick which patients will benefit from AVR? In other words, which patients have group 2 pulmonary hypertension with post-capillary disease, and what is the improvement in pulmonary pressures post-AVR? The graph on the left shows the survival curve of patients with pre-capillary pulmonary hypertension with a PVR or a pulmonary vascular resistance greater than 3 Wood units in the solid black line, did significantly worse than patients with post-capillary pulmonary hypertension with a PVR less than 3 Wood units in the dotted line. Furthermore, the table on the right shows that overall, patients post-AVR had an improvement in pulmonary pressures. However, only those in the moderate and severe range had significant improvements, and despite this, the mean post-operative pulmonary pressures remained in the moderate range with a mean PASP of 45 milliliters of mercury. This is also alarming, and if I can draw your attention to the previous graph, is that patients with moderate pulmonary hypertension had a poorer survival than those with mild pulmonary hypertension. This begs the question of whether patients with severe AS should undergo AVR prior to developing moderate to severe post-capillary pulmonary hypertension. To move on, but consider an important topical issue is patients with asymptomatic severe aortic stenosis. This is not a new area of interest, illustrated by work performed by Catherine Otto and Ian Burwash over 20 years ago, looking at asymptomatic patients with severe aortic stenosis. You can appreciate that the survival curves in patients divided into mild, moderate, and severe peak gradients are significantly different and show poor survival even at 1 year in patients with asymptomatic severe aortic stenosis. Within 2 years, more than 50% of patients with asymptomatic severe aortic stenosis developed symptoms requiring AVR or died. This leads on to the current guidelines recommendations from both the American and European societies for the indications of aortic valve replacements and asymptomatic severe AS. I won't go into all the recommendations in specific detail, but the class 1 indication are those with ejection fractions less than 50% and undergoing open heart surgery for another indication such as CABG. In terms of class 2 indications, there are those who have symptoms on exercise, very severe peak aortic valve gradients greater than 5.5 meters per second, or significant annual progression with a progression of more than 0.3 meters per second per year, signs of heart failure with an elevated BNP 3 times the upper limit of normal, or severe pulmonary hypertension. In terms of randomized trials, the recovery trial published 2 years ago shows that in asymptomatic very severe aortic stenosis, enrolling patients with peak gradients greater than 4.5 meters per second, mean gradients greater than 50 millimeters of mercury, and an AVA less than 0.75, early surgery had better outcomes in terms of operative mortality or cardiovascular mortality out to 8 years versus watchful waiting. So, will TAVI help Mr. AS? So there were 4 questions and concerns which we needed to answer. There is a discordance in the calculated valve area on echo versus the gradients despite normal left ventricular function. How do we account for the degree of mitral regurgitation and mitral stenosis and aortic stenosis in Mr. AS's overall clinical picture? Is there a component of precapillary pulmonary hypertension not accounted for by left heart disease? And is there an ischemic cause for Mr. AS's clinical presentation? So firstly, we performed a left heart cath and crossed the aortic valve. Simultaneous left and right aortic pressures are shown on the left. The peak-to-peak gradient was 26.31 millimeters of mercury, and the mean gradient was just under 16 millimeters of mercury. The valve area was calculated at 1.23 with an index valve area of 0.64. So our conclusion was that the patient had mild to moderate aortic stenosis. When we calculated the left ventricular end diastolic pressure and the pulmonary capillary wedge pressure on the right heart cath, we found a discrepancy. Note that the patient is in atrial fibrillation, and note that there's a large V wave on the wedge tracing suggesting severe mitral regurgitation. This discrepancy in terms of LVEDP to capillary wedge pressure is that you have to note that the capillary wedge pressure provides information on the hemodynamic burden of the left atrium and indicates the degree of left atrial compliance on the pulmonary circulation. The LVEDP, on the other hand, provides a measure of preload and left ventricular diastolic compliance only. The way that we assessed is that this discrepancy suggests that in the presence of MR, large V wave, atrial fibrillation, and to a lesser degree mitral stenosis, Mr. AS's atrial compliance is being affected. We concluded that the pulmonary capillary wedge pressure provides a greater reflection of the overall hemodynamic impact of left heart disease and its direct effect on the pulmonary pressures, and indirectly a marker of its symptoms and mitral valve pathology. It would also be really important to note that it would have been a clinical error to measure just the LVEDP and consider it a surrogate of the pulmonary capillary wedge pressure in a patient with mixed valvular disease, including mitral and aortic stenosis, in particular on the calculation of the pulmonary vascular resistance. To answer this question, to answer the question of whether there was a precapillary proportion of his pulmonary hypertension, we performed a right heart cath and measured his pulmonary artery pressures. His pressures were 53/34 with a mean of 43 millimeters of mercury. His cardiac output was 5.72 with a cardiac index of 2.96. This calculates to a transpulmonary gradient of 9 with a pulmonary vascular resistance of 1.57 Wood units. We concluded that he has post-capillary pulmonary hypertension due to left heart disease. In terms of whether there's an ischemic cause for his symptoms, we performed a coronary angiogram, and you can see from these 4 still shots that he does no significant obstructive disease and some mild to moderate proximal LAD disease. I'll now move on to Dr. Poulin's portion of the presentation and happy to take questions at the end.
Thank you, Kevin, for the first part of the presentation. Now it is my pleasure to do the second part. So I wanted to start with this slide from the TVT Registry 2020 that was published in JACC earlier last year. We can see, if you look over time, that in 2015, TAVR became the most common procedure compared to isolated SAVR across the United States. And in 2019, TAVR became the most common treatment for aortic stenosis in the US in an all-comer population. So that really shows a significant increase. And most of it now probably comes from the low-risk trial. So in the same year, the PARTNER 3 trial has shown that there is an absolute reduction of 6.6% in death, stroke, and rehospitalization at 1 year. In particular, there was a significant decrease in the risk in death, stroke, and atrial fibrillation when you compare TAVR to surgery. The other interesting thing is that there is a significant improvement in the quality of life. These are, when you look at the PARTNER 3 and the Evolute low risk, these are patients with a predicted mortality of less than 4% according to the STS score. The Evolute low risk trial has shown that at least TAVR with a self-expanding valve is non-inferior to surgery. So as we move forward, the absolute number of low-risk patients undergoing TAVR is increasing significantly. So in 2019, more than 8,000 patients were low risk and received TAVR in the United States. And the mortality in that group is actually 2.5% at 30 days, with 95% of those TAVRs being performed transfemoral. So what are the concerns and specific issues? So now that we treat low-risk patients, a few issues are coming up. So valve durability, conduction disorder, and risk of pacemaker, re-access to coronaries, long-term impact of paravalvular regurgitation, although this has become far less common with the new generation transcatheter heart valve. And so that's it. And we also have to remember that in the PARTNER and Evolute low risk, there was a lot of exclusion criteria such as hostile femoral access, recent MI, bicuspid valve, severe AR, complex CAD, low EF, and patients with advanced CKD. So a few exclusion criteria that we have to take on. So the question now is, in TAVR and low risk, is it really better? This data was just published in JACC last week. So they looked at the primary endpoint of death, stroke, and rehospitalization at 2 years of the PARTNER trial, and they've shown that even at 2 years, there is a significant benefit to TAVR compared to surgery. However, the valve thrombosis at 2 years was increased with TAVR compared to surgery. So the numbers are 2.6% for TAVR and 0.7% for surgery with a P of 0.02. So this was diagnosed mostly on echocardiographic follow-up. So these were not clinical events. These were just findings as the study moved on. Some of it were also, some of the patients were also diagnosed with 4D CT to look at a subclinical leaflet thrombosis. So what is the importance of this? Is this clinically significant? So the Cedars-Sinai group has published in 2017 a couple of articles looking at valve thrombosis on CT. They have found that up to 13% of patients with TAVR will have subclinical leaflet thrombosis compared to 4% of patients with SAVR. This has been linked to an increased risk of TIA, but similar risk of stroke. And as of now, there's no evidence suggesting that asymptomatic valve thrombosis, so such as an increase in gradient and subclinical leaflet thrombosis, are related to clinically significant outcomes. I have to say this is an area of ongoing research. Another important issue after TAVR is the late cerebrovascular event that can occur. So a recent multi-center registry that was published last year in JACC Intervention included 3,750 patients with a median follow-up of 2 years. And in that registry, they found that late cerebrovascular events occur in up to 5% of the patients. In those events, 80% of them are stroke, and those stroke, 80% of them are ischemic, the rest being hemorrhagic, and 20% of these patients will experience TIA at 5 years. So in general, this is still a significant proportion of patients, to 5%, and the predictors of this were the age, the presence of cerebrovascular disease, the baseline mean aortic gradient that was higher, the fact that the patient had the periprocedural stroke during TAVR, and the lack of anticoagulation at discharge. Of course, late stroke in those patients was associated with an in-hospital mortality of around 30%. So does the valve deteriorate? That's another question. So a multi-center registry published in 2016 included 1,500 patients post-TAVR with a mean follow-up echography of 20 months. And they have defined the valvular hemodynamic deterioration as an increase in 10 millimeter of mercury of mean gradient compared to discharge echocardiogram. In that study, they found that the incidence is 4.5%. In comparison, the actual partner trial showed an annualized risk of valve hemodynamic deterioration of 1.4%. Factors associated with it, so absence of anticoagulotherapy at discharge, valve-in-valve procedure, small transcatheter heart valve, so 23 millimeter or less, or obesity with a BMI greater than 30. Some other studies, which are mostly retrospective, have shown age can be associated, smoking, diabetes, CKD, persistent LVH after procedure. So there are a few markers we can look at, but the ones in the slides are the main ones. Is anticoagulation the solution if patient has a subclinical leaflet thrombosis or a slight increase in gradient? So this study analyzed over 4,000 patients that underwent bioprosthetic AVR in a pooled cohort or TAVR trials comparing TAVR to surgery. And anticoagulation on a routine basis did not alter the hemodynamics of the valve, but was associated with a slight decrease of stroke after TAVR. Is anticoagulation the solution? I don't think so. I mean, the Galileo trial that was published last year looked at Xarelto 10 milligram versus antiplatelet therapy after TAVR, and in that group there was a high risk of death or thromboembolic event for the patients anticoagulated compared to the patient who underwent TAVR, not to mention that there was also a high risk of bleeding with the Xarelto. So what is the durability of the valve? What can we expect when we discuss with the patient? Because they are likely to ask, how long is it going to last? So a recent paper published by Edelman and colleagues from Atlanta, they've done a really good review on the trials looking at valve durability. So of note, most of these studies are kind of older studies, so they're partner one trial or core valve US pivotal trial. So unfortunately, at that time, the prostheses that were used are not the ones that we use right now. So that's the main limitation. The other main limitation is when you look at the group that is alive at follow-up, you see that more than 50% of patients are dead at 5 years, which is a significant limitation. The other thing that we can note in those trials is as we move on in the data, is there is paucity of data. So it's a small numbers of study, and among those, it's a small numbers of patients. So the durability after 5 years seems good. There's no sign else suggesting it's worse compared to TAVR, but there's still data that is lacking in this area. Another important issue, so apart from leaflet thrombosis, valve thrombosis, and valve durability, is the sudden cardiac death after TAVR. So the risk actually of sudden cardiac death is around 2% after TAVR in a population. And as we go on and on treating patients with low risk, this issue becomes more and more important. The sudden cardiac death represents 8 to 12% of cause of death after TAVR in patients, and the predictors of this are an LVEF less than 40% and the presence of new onset left bundle branch block post-TAVR. In particular, a discharge QRS greater than 160 milliseconds has been strongly associated with sudden cardiac death with an hazard ratio of 4.8. In that context, the Mary trial was published in 2018, and it did include 103 patients, and they looked at left bundle post-TAVR with implanting a reveal. They've found that all arrhythmic events were mostly silent. So 77% of the cases were silent arrhythmic events. 18% of them led to a treatment change, and 11% of these patients required a follow pacemaker or an ICD, either for complete heart block, severe bradycardia, or ventricular tachycardia episode. So in summary, when we look at this, and this is a paper published in 2017 by Ofred, they've looked at the main predictors of left bundle. So implantation of a self-expandable valve, the depth of implantation, the overexpansion, and a large valve size are all associated with left bundle branch blocks. And in terms of risk of pacemaker implantation, then we have to add the baseline right bundle branch block and the first degree AV block. What is the clinical impact of those conduction disturbances? So there was a meta-analysis published in 2020, and this study include there was 2 parts to it. So it includes first 12 studies with just less than 8,000 patients, and look at the impact of left bundle branch block post-AV, and the other one look at the impact of peri-procedural pacemaker, and this one was 21 studies with less than 43,000 patients. And what they've shown is that left bundle is associated with increased risk of all-cause death, increased risk of cardiac death, heart failure, hospitalization, and permanent pacemakers. They've also noted that peri-procedural pacers were associated with increased risk of all-cause death and heart failure, but not associated with an increased risk of specific cardiac death. However, when we actually look closely at this trial, there is multiple limitations. There's a time bias because these studies have been done for up to 2008. It includes multiple devices, and there is, of course, different criteria for pacemaker implantation depending on the protocol of the sites. So despite all the new techniques and even some of the latest data published in 2021 suggests that if you really go for eye implant of the valve, you can lower the pacemaker rates up to 5 or 6%, and same thing for the left bundle. Overall, if you look at the rates of pacemakers over the last 10 years, they haven't gone down a lot. So the risk of pacemaker in 2015 was 15%. And right now it's around 10% as of 2019. And this is data from the TVT registry in the US. So there has been some improvement, but there is still room for improving. So in terms of conduction disturbances, there's been an expert consensus that was published in JACC in 2019 that proposed a standardized approach to patients with conduction disturbances in the context that many centers were using different approaches, so to try to standardize. The most important aspect of this is the pre-procedural evaluation of the patient and the adequate implantation technique, as well as the selection of the transcatheter heart valve. In fact, when you look at the TAVI patients, about 1/2 of conduction disturbances occur before you actually do the valve implantation, so as during wire manipulation or balloon valvuloplasty. So that's something to keep in mind. And in terms of procedural aspect, of course, temporary pacemaker is a main part, trying to avoid predilatation and consider a valve type with lower risk of conduction disturbances, particularly in patients that are high risk. Once the procedure is done, then further management and decision should be tailored on ECG changes after TAVR, accounting for the valve type, your depth of implantation, and the baseline ECG. So in that protocol, multiple studies have showed that if you have a patient that has a normal ECG pre and post procedure, he has a really low risk of complete heart block, and then therefore can be safely discharged day 1 post-TAVR. if your patient has a baseline pre-existing right bundle branch block, then that is a completely different situation. And the reason is the right bundle branch block is associated with increased risk of early and late mortality after TAVR. And this is the most important risk factor for development of complete heart block. In fact, in those patients with right bundle, the risk persists up to, the major risk persists up to 48, 72 hours, and then there's still increased risk in the first 30 days. So in these specific patients, this guideline would argue that continuous Holter monitor can be considered when the patient is discharged, and if any complete heart block, then pacemaker is indicated. If you look at the data, specifically in patients with right bundle branch block, at 2 years, 50% of them will require a pacemaker. This group 3 is the most challenging group. So what is it? It is the patients with pre-existing conduction disorder and that are worsening after TAVR. So either left bundle branch block, IV conduction, intraventricular conduction disorder, or first degree AV block. So there is really limited data regarding this group, and the management varies based on the degree of ECG changes and the final ECG manifestation. So the increase of PR or QRS more than 20 milliseconds or a QRS at the end more than 150 milliseconds is associated with a higher risk of complete heart block. In these patients, it could be either observation. Most of the time we will do 2 weeks Holter to assess for complete heart blocks, and some studies have looked at EP studies with measure of HV interval with limited efficiency. The group 4 is the new onset left bundle branch block post-TAVR. So this represents approximately 25% of patients that will undergo TAVI and warrants at least 48 hours of monitoring. If QRS is less than 150 and the PR is less than 240, then discharge at day 2 is usually appropriate. If the QRS is wider than 150 or the PR is greater than 240, then it is recommended to strongly consider a 2 weeks Holter or an EP study. If there is a continuous widening of QRS after TAVR, which we rarely see, then direct pacemaker implantation can be considered. And this is the last group. So in patients with transient complete heart block during procedure, we will usually suggest to observe for 48 hours. And if the ECG comes back to normal and there's no recurrence, they can be safely discharged at day 2. If there is a recurrence of complete heart block, then a pacemaker is indicated. So this is a really nice algorithm. However, it hasn't really been validated yet. So one of the studies we're doing is looking at this application of the protocol in patients that undergo TAVI. So this is a multi-center prospective study that we're participating. The target of the overall trial is 2,000 patients, and now we're just over 1,000. So in those, we basically apply the algorithm and see what is the outcome. So primary endpoint is incidence of sudden cardiac death in hospital at 30 days and at 1 year follow-up. And the secondary endpoint is a lot of things we're looking at. So rate, timing, and reasons for pacemaker, rate and timing of sudden cardiac death if they occur, the arrhythmic events among the patient that go TAVR, and also based on their valve types that the patient receive, the rate of pacemaker dependency. So there's a few interesting questions there. And another study that we do with the same data is we look at the risk of sudden cardiac death and valve durability. And this is a multi-center retrospective study that we do in North America and Europe. The recruitment is, at least the data analysis is close to being complete. So the target is 4,000 patients to assess for valve durability, as long as we have data and a sudden cardiac death in these patients. So when we come back to the ACC/AHA guidelines that were published in 2020, really the area of controversy is what do we offer to those patients that are less than 65, that have a good life expectancy, but would have a preference for a percutaneous treatment. And in those patients with 65 to 80 years, if they are either TAVR or a transfemoral TAVI candidate, but they have some associated factors, so either coronary disease or other valvular disease, then what should we offer those patients? The answer is not obvious yet. So in conclusion, moderate AS has a significant, Kevin has talked really about this, moderate AS has a significant mortality trajectory that is similar to patients with severe AS. Pulmonary hypertension and aortic stenosis is a poor prognostic factor. Diastolic dysfunction and left atrial compliance are markers of pulmonary hypertension and a really important part of the assessment of a patient with AS. The management of patients with asymptomatic severe AS still needs further investigation, and I think the hemodynamic testing with the left and right heart cath is a really valuable tool in decision making. In terms of once we've done the procedure, then the question is how long is the valve going to last and what are the issues that can come up. So there's no demonstrated association now between subclinical or asymptomatic valve thrombosis and outcomes. The incidence of arrhythmic event and sudden cardiac death after TAVR is fairly low, but still remains an important topic without a definitive answer. And I would say that I think the most important thing after TAVR is a standardized approach to post-TAVR management and complications if they arise. It's a crucial part of patient care, and we hope that these ongoing studies will help us with those decisions. Thank you, and we're happy to take questions if there is.
Thank you, Kevin and Anthony. Dr. Beanlands had to sign off early, but he wanted me to convey that they're both great presentations. There's a couple questions from Dr. Beanlands and myself. If anyone else has questions, please send them in because there is a time delay to when we receive them. So a question from Dr. Beanlands for Kevin. He's curious as to, is there a role of cardiac amyloid in the diastolic dysfunction contributing to the pH in this patient population? Has anyone looked at that?
Oh yeah, there's definitely a lot of work. So there is, and the question is that sometimes things like amyloid are picked up, unfortunately, after the case when patients are non-responders to either surgical AVR or TAVI, and I think that's a really important point in making sure that we pick up these patients prior with imaging if there's a suspicion.
Okay, and another pH question. In the current 2020 guidelines, as you pointed out, pulmonary hypertension isn't really part of the risk stratification in terms of timing or when to send these patients for valve replacement. Based on your work and the literature, how would you incorporate pulmonary hypertension into your practice?
So firstly, if there's a component of precapillary pulmonary hypertension in patients who are considering for aortic valve intervention without other multivalvular disease, then you could almost assume that there would be a component of precapillary pulmonary hypertension post aortic valve intervention. So in terms of the patient's symptoms, it would be very questionable whether they would have any improvement in symptoms afterwards. So I think that's clear from the previous work. Obviously, I showed the trial of patients with severe aortic stenosis and asymptomatic. And the asymptomatic point I raised is because it depends on how hard you look, I think, is that if you if you question the patients, a lot of the times you will elicit symptoms, firstly. Secondly, which I didn't mention because it's a fairly big topic and something else that could be discussed in its own, is exercise, either exercise, right heart catheter exercise, echo, in patients with asymptomatic aortic stenosis, and that can help to stratify the patients who would go to surgery, and that's also recommendations, which is a class 2 for surgery in aortic stenosis. And I think finally, what was I going to say? Oh, yeah, and finally, we may have some more trials coming up also, such as the Avatar trial, which is also for asymptomatic patients in aortic stenosis, and that may shed some light on how pulmonary hypertension affects those patients. But I guess it's a work in progress generally. The issue is that a lot of the times, as you can appreciate, we have an older population, a very heterogeneous group, and then if we add in the components of pre and post-capillary pulmonary hypertension, it does make the decision making more personalised on a patient value rather than a global perspective.
Right. So Anthony, a couple questions for you. Could you talk a little bit about use-versus utilization and early discharge post-TAVI, given the data you've shown regarding conduction abnormalities? So there are some centers that discharge same day as the valve implant. How do you reconcile that with, monitoring for arrhythmias?
Yeah, I think that's a really challenging question. So some centers, at least in Canada, have started to do same-day discharge. I think that's something we could consider in patients that have a completely normal pre and post ECG. The problem is there will be a small proportion of these patients that will develop complete heart block, and we have diagnosed a couple of them lately with this. And the other problem is if you look at 30 days, 75% of these events are asymptomatic. So most of the complete heart block will occur and the patient won't really notice this. And if there's no alter, if there's no monitoring, then it probably won't be picked up. And I think this risk of sudden cardiac death is higher in those patients. So I would think if we are to go this way, and then it would be really to tailor based on the depth of implantation, how the procedure went, make sure that ECG is all okay. And in those patients that would have a really low threshold to do a 2 weeks holter to assess if there's any conduction disturbance after, because we haven't looked at the first few hours. So that's it. It would optimize the resource utilization. I think we're really moving on right now towards trying to discharge them at day 1. So we are a bit in between 60 and 80% of day 1 discharge. So we've done significant progress on that topic. I think in terms of resource utilization, it's also mostly to let the patients know that right now it's a day procedure. So they come in for the day procedure, they just get an overnight observation, and if everything's fine, they go home the next morning. So if it's planned that way, that makes it easier. So it's an important topic, but unfortunately, I think the answer is kind of a case-to-case based in terms of if we can do same-day discharge.
And based on the literature, could you comment, is the mode of sudden death predominantly heart block or ventricular arrhythmia? Is that data known?
That data is unknown. So they've looked at this left bundle branch block. So the MARY trial, which they implanted a reveal in all of the patients with left bundle branch block, but it was a single center, 100 patients, and most of them is complete heart block. So out of the 11 patients that had an arrhythmic event, 9 was complete heart block, 1 was severe bradycardia, and the other 1 was a VT. So ventricular tachycardia and VF probably is still a significant part of sudden cardiac death in this patient, probably related to underlying either LV dysfunction or fibrosis, but definitely this is an area of interest, and if you look at the literature, most of it comes from a complete heart block, the sudden cardiac death. So that's why we're still reluctant and want to observe the patient a bit more.
And one final question, can you just remind us all what is UHI's protocol regarding antiplatelets post-TAVI? You commented that the utility of anticoagulation hasn't been proven, but what is our protocol for antiplatelets? Yeah, so our protocol has been really simple. So if the patient has no coronary disease and no atrial fibrillation, then it will be aspirin alone. If the patient has coronary disease, so if he's got a recent PCI, let's say in the last year, then the antiplatelets are only driven by the coronary disease. So if he's got his TAVI 6 months after the PCI, then we might just do another 6 months of that and then go on to single antiplatelet therapy. So it's really tailored on the coronary disease, not the aortic valve. And if the patient has atrial fibrillation, then we will just continue the anticoagulation without antiplatelets. If it's only AFib, if there's coronary disease, then we'll tailor this to AFib and coronary disease. So we've really simplified, in which case if patient has no coronary disease, no AFib, then it's aspirin alone. That's based on the popular TAVI trials and also the data suggesting that ADAPT has increased risk of bleeding, and Xarelto in those patients has also higher risk of bleeding. So that's why we've gone away from this. Excellent. Well, I want to thank you both for your presentations today. Very enjoyable and informative. I want to remind the audience that there is no Cardiology Grand Rounds next week. It was in anticipation of spring break, which is not really occurring the way we thought it would. Nonetheless, there are no rounds next week. We will resume on March the 24th. Dr. Wang is going to be presenting a topic on atrial fibrillation. So thank you again to our speakers and have a good day. We'll see everyone in 2 weeks.
Thanks.
Thank you. Thank you very much.
Okay, fini.